Welcome to tonight's Lung Cancer Living Room. For those of you who may not know me, I am Danielle Hicks, Chief Patient Officer here at GoTo for Lung Cancer, bringing to you live and in real time conversations from key opinion leaders in the field. And tonight, some of you may have already seen that we will be talking about the best of ASCO, ASCO being the American Society for Clinical Oncology, and it's a big conference that happens the end of May, beginning of June every year, where all the biggest and brightest come together to talk about data from the clinical trials and the new therapies that are being studied. And we've been doing Best of ASCO, gosh, for years now, and it's always one of the most exciting lung cancer living rooms that we have. You know, understanding that a lot of you are, thinking about plans A, B, C, D, and what's coming down the pike and how important that is. And we are all too excited to have Dr. Joshua Sabari flying out this morning all the way from New York. He's at NYU Langone, and we could not be more thrilled to have him out here today to talk to us about what he learned and share it with all of you. I am going to turn this over to you, Josh, and just ask you if you wouldn't mind sharing a little bit about yourself, who you are, and why lung cancer is an area of focus for you.
I got interested in lung cancer probably about 15 years ago. Early on in my residency, I met a young woman who never smoked in her 40s, and everybody thought, this can't be lung cancer, it has to be a pneumonia. And I followed her in the outpatient setting as a resident. And we identified that it truly was a lung cancer, and one of the early EGFR lung cancer patients to respond to some of the early therapies we had at that time. And I was just hooked. The idea that we could change the course of a disease, and gosh, we've come very far since that time, but we still have a long way to go.
Back when my own mom was diagnosed in 2003, EGFR, the biomarker that you just referenced, was still in studies. So when she was diagnosed, nobody was even testing or looking for these driver mutations. And in the last 20 years, because of clinical research, because of clinical studies, more importantly, because of people willing to participate in clinical studies, we have come leaps and bounds from where we were in 2023. Tonight, we're going to be talking about both non-small cell lung cancer and small cell lung cancer, some of the exciting data that came out of ASCO, which I will lovingly refer it to from here on out, American Society of Clinical Oncology, ASCO. And we're going to split non-small cell up into both early and late stage diagnosis because a lot of exciting things over the last, 5 or so years have happened in early stage, particularly as it relates to biomarker-driven lung cancers. So what is biomarker testing and who should have it and why is it important?
It's really all that you need to have to develop lung cancer is lungs. It doesn't really matter if you smoked or never smoked. We know that all people can develop lung cancer. I think biomarker testing is critical because it helps us select the right therapies or the best therapies for individual people. So, in my clinic, every patient, 100% of people will get biomarker testing. And that includes, PD-L1, programmed death ligand 1, which is a marker that tells us whether people respond well to immunotherapy or not. It's an exciting area of development. We also do biomarker testing in the sense of, genomic testing, or to understand what gene mutations may be abnormal. And there are a whole other set of medicines available for patients with gene mutations in cancer. So really, we try to select the best possible treatments. And now we have a lot of these antibody drug conjugates, which we'll mention, ADCs, that are looking at a whole other set of biomarkers. The way I think of biomarkers is just an ability to select the right therapy for the right patient.
It's important to note that that goes for both, therapies that are already approved, but as well as, therapies that are currently in clinical trials. Biomarker testing is quite often, in a lot of cases, required to determine whether or not you qualify for a trial. So I want to jump into the meat of tonight's conversation because we do have a lot to cover about this data. And I want to start with early stage non-small cell lung cancer. You talked a little bit about PD-L1 and how that relates to immunotherapy. So why don't we start with CheckMate 816?
Yeah, so first off, early stage non-small cell lung cancer or early stage cancer in general simply means that the cancer started in the lung and stayed in the lung. We think of different stages, stage 1, stage 2, stage 3, different stages of lung cancer. Stage 2, for example, means that the tumor is a certain size or may have learned to travel to lymph nodes. Stage 3 might be lymph nodes on the other side of the chest. Lymph nodes, remember, just are areas that help fight infection. And when cancers spread, they can spread towards lymph nodes. So understanding the stage of the cancer is critical because stage 1, stage 2, stage 3, early stage cancer is curative in its intent. We are very aggressive in trying to get rid of the disease. Historically, with surgery alone, we have not been as effective at curing disease. And you mentioned CheckMate 816, which is really a revolutionary study bringing immunotherapy and chemotherapy together, medicine called nivolumab, into the early stage setting, right? Immunotherapies work so well in certain subsets of patients who have metastatic or late stage disease. Would patients with early stage disease benefit? And we saw that they do, right? If a patient has a higher PD-L1, that's a marker on the surface of the cancer cell predicting response to immunotherapy, we saw 5-year updated survival that we're curing many patients now with early stage disease simply by getting chemotherapy and immunotherapy before surgery. In those patients who had a lower PD-L1 expression, we still derive benefit, but the benefit is not as robust. So really an area of excitement, an area of research that is ongoing. Do we maybe need to escalate treatment in the early stage setting in certain patients with low PD-L1 expression?
Yeah, I think it's really important because this study is very unique in that historically, whether or not, and correct me if I'm wrong, but whether or not a healthcare provider was going to prescribe an immunotherapy, it was dependent on PD-L1 status being above X, right? But when there were non-expressors or very low expressors, the train of thought was it's not for those people. And this study showed that it does show benefit even in the non or very low expressive PD-L1.
Yeah, that's exactly right. We see the benefit being more dramatic in patients with higher expression of PD-L1, but in those with lower levels, again, this is in combination with chemotherapy. Mm-hmm. So this is really a practice-changing therapeutic. It's something that we're already using in clinical practice. There's also perioperative therapy, which we talk a lot about, which is chemotherapy and immunotherapy before surgery, followed by surgery, and then followed by adjuvant or after surgery therapy. So there's a lot to discuss with your healthcare team in this setting. One really important thing, Danielle, to mention is that you should not get immunotherapy until you know your biomarkers are negative. What do I mean? You need to ask your clinician, your team, did we test for EGFR and ALK and other biomarkers? And only once those are deemed to be negative, meaning that's not what's causing your cancer to tick, then immunotherapy can become an important option or opportunity, because we know that people with driver mutations, those EGFR mutations, ALK mutations, are not generally responsive to immunotherapy. And we'll talk about another exciting abstract that was presented in ASCO showing what those patients who have EGFR mutations benefit from in the early stage setting.
Mm-hmm. And I think I want to point out now, before we get any deeper into this, early stage setting, so cancers that are deemed resectable or like surgically, you're able to remove them surgically at some point. This notion of having some sort of systemic treatment either before or after is not new, right? I mean, historically, it was chemotherapy was used, sometimes radiation therapy, depending upon what we're looking at. But in the advent of targeted therapies and immunotherapies, we've really kind of flipped it on its head. And I think it's important for people to understand that these particularly stage like 1B and greater in the early sort of realm, the recurrence rate was still unacceptably high in those patients with just surgery alone. So I think that's why I just want people to know that's why this is so exciting and this is so important.
I think you hit the nail on the head. Historically, for a stage 1B cancer, a tumor that was 4 centimeters or greater, having a surgeon resect it, cutting it out, there was still about a 20% chance that the tumor could come back over 5 years. And you can imagine as the tumor size is bigger or lymph nodes are involved, the chances of recurrence are even higher. So you're right, Danielle, we've always tried strategies to reduce the risk of recurrence, either by giving chemotherapy first, called neoadjuvant, for surgery, or giving chemotherapy after surgery as adjuvant therapy. And those have been successful, but not nearly as successful as using immunotherapy in the early stage setting. So now that we have immunotherapy in the early stage setting, we're really seeing deeper, longer, responses and more cures, which is the most important thing.
Yeah, I agree. I want to clarify something, and I know we didn't talk about this before, but it is a question we get a lot, and you touched on it, and it's around immunotherapy not being an ideal candidate for somebody who has a driver mutation, whether it's EGFR, ALK, ROS1, MET, KRAS, and TRAC.
And the list goes on.
The list goes on. Yeah. Why is that?
Yeah, so essentially it has to do with the biology of the disease, right? In someone who's never smoked, who has an EGFR mutation, the tumor actually looks different. The immune system responding to that tumor looks different versus somebody who has a history of smoking for many years, 30, 40 years of smoking. The tumor has a different mutational profile, and the immune system actually also looks somewhat different. Interestingly, those folks who have smoked in the past, who have a higher level of PD-L1 expression, tend to have better and deeper responses to immunotherapy. They also generally have high PD-L1 expression on average. But take that young patient who I talked about, diagnosed in my residency program, very low PD-L1 expression, right? Those patients who have EGFR mutations, who've never smoked, generally are not deriving significant benefit from immunotherapy. Now, it's controversial because there are some mutations like BRAF, V600E, which may be somewhat more responsive. You mentioned MET, Danielle, MET exon 14, a mutation that we published on going back now 7, 8 years that may be somewhat more responsive. And we'll talk a little about KRAS. Those are really the 3 driver mutations that we think may have some response to immunotherapy. So it's not as cut and dry as you have a mutation, immunotherapy is not going to be successful. You really need to have a discussion with your healthcare team.
Okay, so stepping away from immunotherapies for a second, let's jump into targeted therapies, and let's start with EGFR, specifically osimertinib, and most of you know it as Tagrisso. What do we got going on there?
Yeah, so just as we talked about the CheckMate 816, using immunotherapy before surgery in patients with, early stage lung cancer to try to prevent recurrence and allow people to live longer, we asked the same question, but what if you have an EGFR mutation? We know that immunotherapy is not a successful strategy by and large in that population. So what have we done? We've moved a medicine, osimertinib. It's a 3rd generation EGFR inhibitor. It's a pill that patients have very good and deep responses to. Can we bring that to people with early stage lung cancer, and will that improve the rate of cure? So this is the NeoADAURA trial. My colleague Jamie Chaff from Memorial Sloan Kettering presented this data, and it was really exciting because I'll tell you that I wasn't too hopeful. Why? Because these targeted therapies are very good at suppressing the disease, but don't get rid of it, right? So there's something that we can measure called a pathologic response rate. What it means is how much viable tumor is there at the time of surgery. And we talk about complete path response rates where there's 0 viable tumor in the specimen after surgery. And what we saw in the NeoADAURA trial is in patients getting chemotherapy and Tagrisso, there was about a 30% rate of a complete response, meaning patients took the Tagrisso, took chemotherapy, and then went to the operating room to have a resection. And at the time of resection, when we looked at it under the microscope, 30% of people had no viable tumor. Now, that doesn't equal cure, and we need to see, sort of longer term follow-up, but it's an early step forward in this space and hopefully something that will be practice changing in the near future.
We talked a lot about combination therapies in this meeting, in other meetings. Chemotherapy is added a lot, right? Whether it's to a targeted therapy or to an immunotherapy. Is the thought that the chemotherapy sort of jumpstarts the targeted therapy, or the chemotherapy sort of cleans up what the targeted therapy doesn't?
Yeah, it's a great question. And that study asked that question uniquely in that it had 3 arms. So patients were enrolled, and again, how important are clinical trials, not just for the patients in the trial getting the therapy, but also for many people who come before and after who may benefit from the results of those trials. So one arm was to get chemotherapy and the osimertinib, the Tagrisso. The other arm was osimertinib or Tagrisso alone. So we asked that question. The last arm was chemotherapy, right? So, interesting when you think about this population, this study, those patients who got chemo and Tagrisso seem to actually do somewhat better than receiving Tagrisso alone. And I think it's the second, the latter. It's really cleaning up any persister cells, any cells that hang around that may have not have been responsive to the Tagrisso, chemotherapy will take care of.
That makes sense.
I would love a future where we can get rid of chemotherapy, but it really is a mainstay in a lot of our treatment paradigms.
Yeah. And I think the some of the earlier trials, and we've talked about those before, looking at osimertinib or Tagrisso in the adjuvant setting, so post-surgical setting, and it really has been game-changing when it comes to clinical practice and how people are thinking about treating these early-stage EGFR positive lung cancer patients.
Yeah, so the ADAURA trial, which is presented now, I think back in 2020, and is a standard of care in my practice, looks at patients who had surgery followed by chemotherapy to prevent recurrence, and then patients were randomized to either get osimertinib, Tagrisso, the EGFR inhibitor, versus placebo. And what we saw is that in those patients who got osimertinib, they truly lived longer. And the reason that study was so controversial was, can't you just wait to see who is cured? And if somebody recurs in the metastatic setting, meaning when they recur, when the cancer comes back, can you give the osimertinib at that time? But we know that if the cancer comes back, the intent of treatment is no longer curative. So we really want to give aggressive therapy up front. Now, there is a cost, not a financial cost. There surely is a financial cost, but also a toxicity cost. And I think, in patients who have early stage disease, stage 1B, you may hold it back and you may have that discussion with patients. But in patients with stage 2 or stage 3 disease, it really does make sense because the risk of recurrence is higher. Giving the osimertinib, the Tagrisso, is going to reduce the risk of recurrence. Now, Danielle, whether to do it for 3 years or longer is always controversial. The study, set out 3 years, but we know from a separate trial, the LAURA trial, which is in patients who could not get surgery, but had stage 3B or 3C. Those are tumors that are larger or have more involvement of lymph nodes who get chemotherapy and radiation. We give the osimertinib indefinitely. Okay, so, we don't stop that therapy. So really a discussion to have with your doctors in your practice.
So we learned a lot in the EGFR space. And of course, back then, people who had biomarkers other than EGFR were thinking, what about us? What are we looking at when it comes to some of these other ones? So can you talk a little bit about the ALINA trial?
Yeah, I always have patients who come in and say, why is everyone always talking about EGFR? What is so special about EGFR? There's really nothing special about it, and just that it's common, right? It happens in 20 to 25% of people. There are some rare EGFR mutations like exon 20, the location of that mutation, or there's some other rare subset that don't respond well to osimertinib. And then there are many other mutations as well. So the ALK fusion, ALK fusion, is also quite common, right? It occurs probably in 3 to 5% of people, more common in people who've never smoked, especially, more common in younger folks. And, there in that setting, we have a lot of successful therapies in the metastatic setting, alectinib, lorlatinib, brigatinib, and others being developed in the setting. And we asked that same exact question, what about people with early stage ALK-rearranged lung cancer? Can we study some of these oral therapies in that setting? And that's the ALINA trial, where we randomize patients post-resection. And here, the interesting caveat is they did not include chemotherapy in this trial. After surgery, patients after surgery were randomized to get alectinib, a next-generation ALK inhibitor, versus placebo. And what we saw was a significant improvement in the risk of reduction in those who got alectinib. I still give adjuvant chemo. I think it's important because it's curative in intent. And I do give alectinib now in that setting. Also a very well-tolerated medicine, but there's clearly cost for any medication, and it's important to have that discussion with your doctor.
Yeah. It's important to note that the team approach associated to this.
We call it a multidisciplinary team, and I'll tell you, 10 years ago when I started practice, it would be very uncommon for me to see a stage 1 patient in clinic because the surgeon told the patient, you are cured, even despite that there is a 20% chance of recurrence. But in someone who had stage 2 cancer, sure, those patients would come and see the medical oncologist and would be offered therapy after surgery. Now, because we have so many effective therapies that we can give even before surgery, it really behooves all patients to see medical oncology at the same time that they're seeing the thoracic surgeon. And we have a multi-D clinic, so the surgeons can't avoid us. They're on our floor, in our building, on our team. So, when someone comes and meets the thoracic surgeon, they're also meeting the medical oncologist and sometimes even the radiation oncologist as well. Now, I know that's unique at a lot of academic centers. At some community centers, they may not be physically present in the same building, but really push on your team to have this multimodality approach. It's critical in 2025.
Yeah, I agree. We've talked about early stage and we've really begun that at 1B. Why are we starting these conversations at 1B as opposed to 1A?
Yeah, it's a great question. We know that 1B or greater historically, and that has changed over time in the staging system. A lot of patients ask me, what makes me 1B or 2? It really is us taking in a lot of data from people who are resected and monitoring to see how they've recurred. We're now up to the 9th edition for the AJCC, and these are huge databases of patient information. So these change over time, and we add new information to this database. So someone who's 1B today could be stage 2 in the future or vice versa. But something that is smaller than 1B, okay, tumor size, or doesn't have any high-risk features, the chances of recurrence are so low. You still should have a discussion with your team, but really the risk of using some form of therapy to reduce recurrence, it doesn't really outweigh, the risks don't outweigh the benefit there. And that's really why a lot of these discussions start with 1B. Now, we're having ongoing trials of tumors less than 3 centimeters or even 2 centimeters to try to better understand. Maybe it's more than just size. Maybe it's the biology of the tumor that really matters.
Yeah. Staging is important. But quite often after surgery, people are restaged. So even if prior to surgery, you were staged at a 1A, sometimes they get in there and they realize, we're seeing something here that we didn't see on a PET scan or whatever. So I think that's an important thing to pay attention to as well, because sometimes that can even fall through the cracks.
I think one of the most important visits is meeting with a person after their lung cancer surgery to go over that pathology report, because some patients will be upstaged, have higher stage disease, and then the treatment paradigm changes. Some people will be downstage, right? What we thought was there is much less, right? Maybe there was a lot of inflammation or scarring around the tumor. So such an important point to sit down with your surgeon or your medical oncologist to go over that pathology report. I put a lot of emphasis on that, visit. So making sure the patient really understands everything that was done to them and what the true stage is. You're right, because a lot of our treatment paradigms really depend on the stage of the cancer.
Non-small cell, late stage. You mentioned there's different types of EGFR. Let's talk a little bit about exon 20.
So for late stage disease, now we're talking about stage 4 cancer. So cancer that starts in the lung, learns to travel somewhere else in the body. And it could really be anywhere in the body, and it's sort of outside of the chest. And that's how we think about it. Really important that in some folks who have very limited, disease outside the chest, we may even treat them in an earlier stage paradigm, depending on their age and their comorbidities. But in someone truly with metastatic or disease that has gone outside the chest, we, consider therapy, more palliative, right? We're not going to cure or get rid of the disease, but we're going to treat, and we're going to treat aggressively, and we're going to focus really on quality of life. And so many patients do so well with metastatic cancer. So EGFR has been a poster child of that, right? EGFR exon 19 and exon 21, these are the locations of those gene mutations. Patients have derived a lot of benefit from oral therapies, these pills, tyrosine kinase inhibitors. EGFR exon 20 insertion, that's a more rare mutation. It's one that I study and have done a lot of work in trying to bring new therapies to patients. those folks do not respond well to osimertinib, Tagrisso. So we need to look at more options, more therapies that are available. So we saw very exciting data at ASCO 2025 with a new therapy, a medicine called zipalertinib. It's a mouthful, but Zipa, Z-I-P-A, lertinib, L-E-R-T-I-N-I-B. And it's a novel next-generation EGFR exon 20 specific inhibitor. So remember, historically, we had drugs that blocked all of EGFR and maybe other mutations as well, so they were non-selective. Now we have medicines that are so narrowly designed that they just block the mutation at hand. And that's important because it limits the side effects, the toxicity, and may even improve upon the efficacy. So we saw very exciting data in a single arm study. So we don't have a control arm, it's still early, of a medicine called zipalertinib. And one important thing to note is it even worked after prior medications had failed patients, such as amivantamab. Amivantamab is one of the standard EGFR therapies that we are now using in practice. This drug, zipalertinib, is ongoing in a phase 3 trial. So we're comparing zipalertinib plus chemo, patients newly diagnosed with EGFR exon 20, to chemotherapy alone. And there it is. Why do we have to include chemo here? Again, we know that chemotherapy together with zipalertinib may derive longer-term benefit for patients.
Yeah. I think a lot of people hear the word chemotherapy and they're afraid of it, right? Because it's like my grandfather and my great-grandfather's chemotherapy. And we've come a long way with chemotherapy, and not only chemotherapy, but supportive therapies to help with any potential side effects, right?
That's a great point, Danielle. A lot of the chemotherapies that we use now are better tolerated than the therapies we've used in the past. You know, a lot of patients come in and ask, what about hair loss? What about nausea? A lot of the medicines that we use now can really avoid a lot of those toxicities. Again, really important that you talk about these with your team and not to sort of write off any one treatment because of what you've seen or heard from family members years ago or what you've seen on TV, because really the therapies of today are far better.
What about the EGFR with MET amplification?
Yeah, so that's really an interesting abstract that we saw at ASCO 2025. So we know that EGFR mutation is common, and moving away from the uncommon EGFR, moving back to the common EGFR mutations, exon 19 deletion or L858R, most commonly people are getting osimertinib in the frontline setting, or more recently, osimertinib plus chemo. And there was recently a third approval of amivantamab plus lazertinib. So there are 3 different regimens that are approved. But we know that these therapies do not cure, do not get rid of the disease. And essentially, unfortunately, all people have recurrence of their cancer. So what do we do at the time of recurrence? Well, you know, you mentioned option B, option C, option D. So important to have all of these options ready to go in your armamentarium. So option B for a lot of patients with EGFR mutant lung cancer is to reprofile the tumor, to better understand why is this cancer no longer responding to the osimertinib or the prior treatments. And one of the more common resistance mutations, resistance means the reason why the cancer is no longer responding to prior treatment, is MET, and something called MET amplification, which is the gene copy number is high. There's a lot of that, you know, allowing for resistance. And one of the studies we saw presented from a group in China was a novel MET inhibitor, a pill called savolitinib, in combination with osimertinib. And what we saw was impressive response rates and impressive duration of response. Again, single arm study. What that means is there was no control arm. So we don't know how it compared to a standard of care. There is an ongoing phase 3 study now, the Saffron trial, comparing it to a control arm. So I hope that this is something that is available in the future for patients. Again, not for all people, but for people with MET-mediated resistance.
Perfect. Now I want to jump to KRAS. We talked about, you know, EGFR being one of the more common, but KRAS is
probably the most common mutation.
Common. And then to complicate things even further, there are different subtypes of KRAS, right? So let's start with G12C.
Yeah, so Danielle, I think you hit it on the head where you said complex. KRAS is one of those fields that is immensely complex, and it's been heavily studied since the 1980s, and it was termed, even when I was training, not so long ago, and I know I look old, but not so long ago, the undruggable mutation. Why? Because everything that we've tried has really, failed patients, right? So now, with understanding the different subsets of KRAS, we call them alleles. It's the different sort of, not just the street you live on, but what is the actual address to your house? That's really what the allele is. So KRAS G12C, one of the more common KRAS mutations, it probably makes up about 12 to 14% of non-small cell lung cancer. So we see it very commonly in our practice. 2 drugs now FDA approved, adagrasib as well as sotorasib, and these are approved post-progression or as a plan B after people have growth on chemotherapy and immunotherapy. And they're very good therapies, but again, as we said, we need better and we need more for patients. So at ASCO 2025, we saw 2 really exciting and important abstracts where we take the success of some of these agents in the later line and we say, can we bring it into people newly diagnosed? So the KRYSTAL-7 trial looked at adagrasib in combination with chemotherapy and immunotherapy, or in combination with immunotherapy. And what we saw was profound activity. So in people that were high PD-L1, remember, PD-L1 is that marker on the cancer cells that tell us whether immunotherapy will be successful. In people with high PD-L1, we saw robust responses and very durable long-term responses. What we saw at ASCO 2025 was the data from those people who were lower PD-L1 expressors, 1 to 49. Those folks still benefit from the combination of adagrasib and immunotherapy, but the time of improvement on therapy appears to be somewhat less. So further studies need to be done, and those studies are currently ongoing. We also saw a new medicine, and I'm participating in the trial, so full disclosure, LY982, also now known as olmorasib, and we also moved that drug into the early stage setting, showing very interesting and exciting data. One important thing to mention is the toxicity, right? With everything that we do, there is a cost. I talk to patients about this idea of there is no free lunch, right? Anytime you see a sign for free lunch, it's always like, sign up for this, right? There's no free lunch with the therapies that we use. So we know that when we combine KRAS G12C inhibitors with immunotherapy, there's always an increased risk of adverse events that are related to the immune system being overactive. And one of those common ones is liver abnormalities. So we want to watch those closely. And that's something that we were really focused on for those 2 abstracts.
Yeah. What about G12D?
Yeah, so first off, if you have a different KRAS mutation, you can't use adagrasib and sotorasib. It only works in those folks with G12C. It's a common question I get in my practice. What about G12D, which is a different mutation? Probably occurs in 3 to 4% of lung cancer. Interestingly, in colorectal cancer, very common, right? So we know these mutations are not specific to one type of cancer. KRAS G12D, we saw exciting data at our AACR conference, American Association for Cancer Research, which just happened also interestingly in Chicago just a few months ago. There was a medicine from a company called Revolution Medicines, a very small, early company, RMC9805. That's sort of the license plate number for the medication. We now have a name for it, but I just can't remember it at the moment, where we saw impressive response rates. And I think that's the first therapy that will likely move forward in lung cancer in people with KRAS G12D.
Yeah, which is exciting. I mean, I think it's really exciting for those with KRAS in general, just to know that more options are coming down the pipe.
Historically, people who've had KRAS have not benefited from targeted therapies, and I think that has really changed over the last 2 to 3 years.
What about HER2? I know historically thought to be associated with breast cancer. What do we know about HER2 in lung, and what happened at ASCO?
Yeah, so HER2 is one of those sort of, mutations that has not got a lot of attention in lung cancer. Why? Because it's rare, right? So HER2 mutations occur in probably 2% of folks with lung cancer, and that's uniquely different from HER2 overexpression. Simply stated, if you biopsy someone's tumor and you look at it under the microscope, HER2 expression is the level of protein on the surface of the cancer cell. And we do see overexpression of HER2 in lung cancer, and that's what we're generally talking about in breast cancer. But for lung cancer, what really matters is the HER2 mutation. You can't see that by staining the surface of the cell. you really need to do next generation sequencing or broad panel, NGS we talk about, where we can identify all mutations in the cancer, and HER2 mutations are one of them. And they're rare, 2 to 4% of lung cancer. We do have an approved medicine, Enhertu, or trastuzumab deruxtecan, but it's an infusion and it's an antibody drug conjugate that has chemotherapy-like side effects. So at ASCO 2025, we saw updates on a medicine called savolitinib. Its license plate number was BAY292. And that's an exciting drug that blocks HER2, has a great response rate, also has great durability, but does have some side effects such as diarrhea. It's an off-target effect of the medication, and we hope the drug will be approved shortly. At AACR, we also saw a drug presented called zongertinib. Its license plate number was BI181, and that's a medicine that I've been heavily involved with developing. Also, very high response rates, very durable responses. To me, better toxicity profile, less diarrhea, less rash. So if you have, a HER2 mutation or a family member has a HER2 mutation, please talk to your doctors, your teams about these medicines.
Yeah, I think I wrote down a couple of things. You talked about NGS or next generation sequencing. You've heard us talk biomarker testing, but this comprehensive biomarker testing, molecular testing, genomic profiling, it goes by many names, which can also be incredibly
confusing. I agree. Yeah, historically, when we talked about biomarker testing, it could have been as little as just testing EGFR, ALK, and PD-L1. And that's a good start, but it's not the whole story. That's like reading chapter 1 and 2, but not finishing the novel, right? You really do need to do broad testing. So we need to understand all genes. Now, do you need a 700 panel, study? Maybe not, but you want to talk to your team and say, hey, is everything that is approved or that is available in trial going to be tested in this panel? And your clinician, your team should know the answer to that. So, doing piecemeal testing in 2025 is insufficient. You brought up liquid biopsy, which is really something near and dear to my heart, something I've studied now for the past probably 12 years. And the best analogy I tell my patients is when you go fishing and you don't catch a fish, it doesn't mean there were no fish in the ocean that day, right? That's critical. So when we do a liquid biopsy, we are literally fishing for a mutation. And sometimes it comes back and we don't identify anything. That test is non-diagnostic. It doesn't mean that you don't have a mutation. You still need to fall back on the gold standard, which is tissue-based testing. Again, liquid biopsy, if you find it, great, you can act upon it. But still, tissue testing is the gold standard.
Yeah. We're slowly seeing in more and more people stage 4 lung cancer becoming chronically managed.
100%. And if you look at the time that people are on therapy or the time people are alive, there's a dramatic improvement of success in the last just 3 to 4 years. And if you look back historically, right, when people were diagnosed with stage 4 lung cancer, I spoke to someone earlier, there was no hope. There is a tremendous amount of hope now. I mean, we're sitting behind the hope wall. There's a tremendous amount of hope. There are so many different treatment options available. I think one thing I try for every single person I meet when they leave my clinic is to leave with a sense of hope and optimism that there are so many opportunities available to you. And you mentioned it, it's become a chronic disease. It's a tough chronic disease, but it's a chronic disease that we're able to manage in practice.
I want to jump to small cell. If nobody has any other questions, we've got 2 really important studies that I want to talk about. Let's start with the Delphi. We've talked about tarlatamab a little bit in here at some of our meetings specifically targeted towards small cell lung cancer, but what's going on there?
Yeah, so small cell lung cancer is a different disease with a different biology. So one of the tough things about small cell is that the mutations in small cell were not really responsive to targeted therapies. And we've gone 20 some odd years without dramatic improvements in the outcomes for folks with small cell lung cancer. And we're specifically talking about extensive stage or metastatic small cell because the treatment is different for early stage small cell lung cancer. So when someone newly diagnosed with the metastatic small cell, the standard of care has been chemotherapy plus immunotherapy. And despite the initial successes being high for chemotherapy and immunotherapy, it's one of those diseases that the recurrence rates are too high, right? And it's a really tough disease. The Delphi 304, the tarlatamab study, really is one of those practice-changing trials, right? It's a new medicine with a novel mechanism of action, due to the science, in the laboratory over the last 10 plus years. We've been able to better understand immune cells, and we're able to target immune cells. So this is a medicine that is called a BiTE, or a bispecific T-cell engager. You might say, explain that in English. What does it mean? So it's an antibody that has two arms. One of the arms blocks something or binds to something called DLL3, which is expressed on all small cell lung cancer cells. The other arm of the antibody blocks something called CD3, which is something expressed on immune cells, particularly T cells, that help engage the immune system. So imagine if you can take an immune cell that's literally looking to kill things that are foreign and bring it into proximity with a small cell, you get really robust cell kill, really robust immune responses. And that's exactly what we see from tarlatamab. Some of the concerns for the medicine is that it can cause something called CRS, or cytokine release syndrome. In English, it's just getting your immune system too active, right? We see it commonly in people who have infections where their immune system gets too active. So if we can calm the immune system down, and this medicine requires an inpatient admission for the first two administrations, and then we can also see some neurological complications, confusion, for example, again, related to the immune system being overactive. We've given this medicine now many times, and we led one of the trials, so we have a lot of experience with it, and a lot of academic sites using this medicine a lot. I would say the last month or so, I'm starting to see it also in the community, so it's getting out there for patients. So the Delphi 304 compared tarlatamab to standard of care chemotherapy, and tarlatamab reduced the risk of mortality by 40%. That's really a dramatic improvement. We haven't seen any numbers like that in the lung cancer space in the last, I would say, 30 plus years.
Yeah, it's crazy. And it's so exciting for a community, like you said, who has had nothing new for, over half a century. So what about IMforte?
Yeah, so the IMforte is also a really interesting study. So remember we talked about someone who's newly diagnosed with small cell lung cancer that is extensive stage or metastatic. The paradigm was to give chemotherapy and immunotherapy together for 4 cycles or 4 times, and then to give immunotherapy in the maintenance setting. So the IMforte study asked the question of, in the maintenance setting, could you add a novel chemotherapy called lurbinectidine? And that's exactly what that study did. So it looked at lurbinectidine plus atezolizumab, a PD-L1 inhibitor immunotherapy, versus atezolizumab alone. And we did see a dramatic improvement in survival in that patient population as well. So things are rapidly evolving and changing in the small cell lung cancer space. So really 2 FDA approvals in the last couple of weeks, which is exciting in a disease where we call it recalcitrant, right? We really haven't had historically many opportunities. For me, this really blows open the doors for many other therapeutic options. We saw many antibody drug conjugates presented, other bispecific inhibitors at ASCO 2025. So I think over the next coming years, we're going to see many advances in the small cell lung cancer space, and we hope to make it into a chronic disease similar to non-small cell lung cancer.
There was a study in looking at immunotherapy and the time of day the drug was administered. Is it a big splash? Does it matter? What are we looking at there?
Yes, this was one of those interesting abstracts that I didn't really have a lot of data or knowledge on. And, I went there, I saw the abstract, saw the discussion. It was interesting. It stated that if you received immunotherapy earlier in the day, and remember, it's a randomized trial. Half of people got immunotherapy, I think it was before 3 p.m., right? Hopefully most people's days are winding down by 3 p.m., right? But, you never know. And then the other half got immunotherapy after 3 p.m. And what they found is that those folks who got immunotherapy before 3 p.m. seemed to do better. So is there a biologic rationale to that early bird, right? That early riser, the person getting immunotherapy earlier? The problem is that there are so many, sort of caveats or variables here. Again, the study is randomized. The reason we randomize things is to get rid of as many of those sort of confounders as possible. But you can imagine, people that get up earlier maybe are more active, or maybe there's more nursing staff there earlier in the day than later. But, or maybe there's something about the immune system where it's more active earlier and then later in the day it's less active. So we don't have a great explanation. Also, immunotherapies have very long half-lives, right? They stay around in the body for weeks to months. So why does it matter when you get it? It's an open question. I think we need further studies in this space, but definitely one of the splashiest abstracts at ASCO 2025.
Yeah, I think it's fascinating. And I think it points to, not all studies and not all data reported out on have to do necessarily with a new drug or a therapy. There's all different kinds of clinical trials out there. Thank you so much. I know ASCO, we normally do this one in July, and I know this was a quick turnaround because it just ended a couple of weeks ago, so I really appreciate you coming out and having this conversation. And ASCO, I always compared it to like speed dating, where it was just like there's so much, you're here, you're just like all over the place, getting a ton of information. So it's really important, I think, that we let folks know. Anybody who is watching who wants more information on anything we talked about, please just reach out to us, either Michelle or I, or really any of you can call the helpline if you want, and we can make sure to get you more information or answer any questions you might have as this sort of all soaks in. And before I give my thank yous, I want to give a special thanks to all of you who either currently are or have participated in clinical trials. I know I said it in the beginning, but I mean it from the very bottom of my heart, and I do not think you guys are thanked enough for your participation. We absolutely would not be where we are in medicine today without people like you. So thank you so much for that. Thank you again, obviously, to Josh, Dr. Sabari, for coming out here and having this conversation. Onyx and Ash, Penn Media for coming in here and getting all of this crazy stuff set up for us. And then, of course, our supporters, AbbVie, Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Novartis, Novocure, Regeneron, Takeda, Oncology. Without your support, we couldn't continue to bring this very important information and education to our community. So thank you all. Thanks, guys.
So I'll be brave if you're brave. I'll be brave, but only